All right. So we've been talking about diabetes mellitus, and then today we'll be looking at something still on diabetes mellitus. Today we'll be talking about some of the metabolic complications that can result in diabetes, and this is quite common because when you are in the ER and they bring you a case to see, most likely this patient that you'll be seeing won't just be a patient you are going to put on metformin and maybe a sulfonylurea and say, okay, go home and come back later and let me check your fasting blood sugar. Most of the cases that will come to you at the ER would be, in terms of diabetes, would be cases that will require that you be able to stabilize and, prompt response, resuscitate, control blood sugar. Otherwise, you end up losing your patient. One of the complications we talked about previously was hypoglycemia. Today, we'll be looking at the opposite, which is hyperglycemia in the diabetic patient. Okay, so that's what we'll be talking about today. So we'll look at some definitions as a recap. We'll look at risk factors, pathogenesis for this hyperglycemic complications. We'll also look at clinical features and how to investigate our patients and then how to manage our patients. So our previous lecture, we said that usually when the fasting blood sugar is 7.0, greater than 7.0, 7.1, or your random blood sugar is greater than 11.1, after 2 hours of your meal, then we say that we can actually categorize or put you in the diabetic range. It means that you need to be managed. And we said that the management goes in two ways. It's either we are doing a non-pharmacological management or a pharmacological management. Sometimes the non-pharmacological management is able to sort our patient out and control the sugar in a way, but most patients will go on to need pharmacological management, which we talked about in our previous meeting. We talked about the types of oral hypoglycemic agents, and we also talked about insulin. Usually your diabetics can present with elevated sugar levels, and we are looking at sugar levels above 18 millimoles per liter. And this sugar levels above 18 millimoles per liter will have to prompt you to start management just to keep it controlled or keep the sugar reduced, because once your sugar hits 18 and goes beyond 18 millimoles per liter, then basically it means there's something actually wrong. And if you start practicing, or those who are practicing already doing locums, you realize that most of the diabetics that will be rushed to you, or most people that will be rushed to you to the OPD or the ER with a history of diabetes would usually have an elevated sugar. And most of the time the sugar is above 18. And once the sugar is above 18, you as a clinician, it's not enough to say, oh, let me give you metformin or let me give you Dianel and go home. What you have to do is to institute management protocols to control the sugar and investigate the reason why the sugar has gone up beyond the normal range. So basically that's what we'll be looking at. So in terms of hyperglycemia in diabetics, usually when we say that their sugars have gone extremely high, there are two categories that we tend to look at. We look at what we call the diabetic ketoacidosis, what we call the DKA, or we look at the hyperosmolar hyperglycemic state, what we call the HHS. As we go on in this lecture, we'll get to understand what the DKA is and what the HHS is. Okay, but whenever you, as a clinician, you see a patient who is a diabetic, you check the sugar and your sugar is gone above 18, you should be thinking about these two things, that okay, could it be that this patient is developing some form of diabetic ketoacidosis, or could it be that this is actually going up and is going to result in what we call HHS or osmolar hyperglycemic state? How does this happen? We'll get to know in a bit. So let's take diabetic ketoacidosis. It's something that we tend to see often in the emergency setting, and it's something that tends to kill the patient if you don't manage it properly. Because once we say that you have a DKA, it's not just about your blood sugar going high, but also the fact that this blood sugar going high is going to trigger other things, and it's going to make your homeostasis or your system a little bit acidic or acidotic, as the name suggests. And it's also going to lead to fluid and electrolyte imbalance. This is what is usually going to kill you. So, as I said, you might see a diabetic patient whose sugar is probably above 18, and then you say, oh, okay, let me just give you metformin, it will go down. This patient will go home, forgetting that there's something which is actually triggered the sugar to go up above 18, because for all you know, maybe this patient might be taking his or her medications. However, the sugar will still be up. Or for all you know, this patient might be having some sort of infection which has caused the sugar to be up. If you don't investigate and pick up these things, and you just see the patient on OPD basis and you send the patient home, the patient will come back to you in a worse off state, because by the time the patient comes, all these things in terms of acidosis and dehydration would have set in, and it would make management very difficult. So we are looking at DKA, and usually we say that DKA would happen when there's total insulin deficiency. What does this mean? You remember our previous lecture, we said that in terms of diabetes, you can have type 1 diabetes where you have total insulin deficiency, or you can have type 2 diabetes whereby there's insulin. However, the system is unable to respond to the level of insulin, what we call insulin resistance. And usually that would be type 2. But we also said that patients who have type 2 diabetes would later go on in life to also develop some sort of total insulin deficiency. So even though DKA is a classic thing for people who don't have insulin at all, and we are going to see why, and this is more common in type 1, it can also become so uncontrolled that they've gone past insulin resistance and they also have insulin deficiency, as we said in our previous lecture. So when do people develop DKA? Usually if you have a diabetic patient who doesn't know he's diabetic and so it's not on medications, and the sugar keeps going up high and high and high, and this patient has gone beyond the point of insulin resistance to the point of insulin deficiency, or if it's a type 1 diabetic, this patient actually has insulin deficiency but doesn't know, sugar level goes up, 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 up. It gets to a point where by DKA will set in, and then we'll start seeing the clinical features of DKA. Also, you might have a patient who is on insulin, but then would sort of be non-compliant to the insulin therapy, and so would definitely develop insulin deficiency. And once you are deficient of insulin and you still eat, sugar levels are going to go up and you are going to have issues there. Also, when you are sick, the stress hormones that we talked about in our previous lecture, which we said that oppose the action of insulin, like glucagon, like the growth hormones, like the adrenalines, the thyroid hormones, like the cortisol, all the stress hormones, they act opposing to insulin. And these hormones will usually go up when you are sick. When you are stressed, it would usually go up. And with this reason, once it goes up, then it means that your it's going to cause the liver to release more glucose into the bloodstream. And already you are having some form of insulin deficiency, blood glucose will go up, and hence you are going to have issues of DKA. Let's look at the actual pathogenesis or the actual reason behind this DKA. Once we are looking at DKA, as the name suggests, we are saying what's ketoacidosis. So it tells you that the system is going to develop, it's going to become acidic, or you're going to have an acidotic state. And this acidotic state is going to be secondary to ketones, as you can see, ketoacidosis. So that's where the name comes from. And these ketones or ketone bodies are actually produced from your breakdown of your lipids, where you have fatty acids and glycerol, and then breakdown of your fatty acids. This fatty acids, once broken down, will lead to ketone body production. And these ketone bodies have the tendency to basically make the system acidic, and that's where the disease gets its name from, ketoacidosis. In a short while, we are going to know why fatty acids are broken down when the system has enough glucose. So what is happening is, once you have insulin deficiency coupled with excess, should I say, anti-insulin hormones, or these hormones that act opposing to insulin, like glucagon, cortisol, adrenaline, growth hormones, what is going to happen is that when you eat, or even when you are starving, the liver is going to release excess glucose into circulation. The function of insulin here, insulin as a standalone is supposed to fight the action of these hormones that have been listed there, to ensure that the sugar in the bloodstream is within the normal levels. But once the insulin level goes down, then it means these four hormones here, glucagon, cortisol, adrenaline, growth hormones, they are going to have a field day, and they are going to cause excess production of glucose, excess release of glucose into the bloodstream. And once these sugars go up, what we expect is that, oh, now we have a lot of sugar in the bloodstream, so the body should be able to utilize the sugar. If we say the body, we are talking about the muscles and then the fat cells. That is what feeds on the sugar and whatnot. So you should be able to utilize the sugar. But mind you, we said that for muscles and fat cells to be able to even use the sugar, we need insulin to push the sugar into the muscles and into the fat cells, if you remember our previous lecture. So once this glucagon, cortisol, adrenaline growth hormone, once they are all working and releasing, causing an increased hepatic output of glucose in the bloodstream, your system now has abundance of glucose in the bloodstream. However, this glucose only remains in the bloodstream and is unable to get into the body cells where it is needed most. So even though you have excess sugar in the bloodstream, your body is unable to make use of this excess sugar. And that's why our previous lecture, I told you that diabetes can be defined as what? Starvation in the midst of many, like a rich man who has all the food in the world at his disposal, but he's still starving because he's been banned from feeding. And that's exactly what happens. You have excess sugar in the bloodstream, but then it's unable to enter into the cells. So even though you have this excess sugar, your body feels, no, I'm actually starving. Meanwhile, there's actually a lot of sugar in the bloodstream, but your muscle and your fat cells would starve. And whenever you are starving, your body will go to the next source of energy source. And this is the fatty acids, or should I say in this case, the lipids. So because your glucose levels are high, but your body is unable to make use of the glucose, your mind feels, or your system feels, you actually don't have food in the system. So it goes to the fat stores to generate energy. And in so doing, it breaks down these lipids into fatty acids and glycerol. And these fatty acids can then be converted through a process where you make fatty acyl-CoA, and eventually you end up making ketone bodies. So that's basically the pathophysiology. Ideally, you are not supposed to touch the fat cells or the lipid sources for energy. You are not supposed to touch it until you are starving. But in the diabetic, because the body feels they are starving, even though they have excess glucose in the system, because of that insulin deficiency, this excess glucose in the system doesn't feed the body cells in any way. So the body feels there's actually no sugar in the system. Meanwhile, there's a lot of sugar in the system. And the body will hence go to break down the fatty acids and glycerol. It breaks down fatty acids just to make energy. And in so doing, will lead to the production of ketone bodies. And that's, once you have these ketone bodies being produced, that is when you start developing what you call diabetic ketoacidosis. So the blood glucose will still be at an increased level, and this high level of blood glucose is going to cause you to urinate. And because you are going to pee often, you are going to sort of pee, and the pee will be highly concentrated with glucose. You have what we call glycosuria. And this glycosuria, because it's concentrated with glucose, is going to draw fluid, excess fluid with it. So you urinate, and the urine will be in large volumes, what we call polyuria. And this excess urination can actually lead to fluid and electrolyte imbalance, and then it can lead to dehydration. So that's the first step. And two, once you break down this fatty acids and you start accumulating ketone bodies, your body is now going to develop what we call, or you are going to go into what we call metabolic acidosis. Okay, metabolic acidosis means that you have increased acidic levels, or decreased pH levels secondary to a metabolic process. And this metabolic acidosis will usually come with vomiting, and this vomiting would worsen the fluid and electrolyte depletion. Already you are urinating a lot through osmotic diuresis, so you are having some form of dehydration. Now, if you add the vomiting to it, then clearly you are going to lose more fluids, you are going to lose more electrolytes, as you can see. And this fluid and electrolyte depletion would eventually lead to shock. If you are losing more fluids, you are going to eventually have poor perfusion to the kidneys. So you are going to develop shock. Once you develop a poor perfusion to the kidneys, what will happen? The kidney would be unable to excrete waste substances, or the kidney will be unable to get rid of substances that is supposed to excrete these ketone bodies. But because of the shock that you've gone, like you are facing now due to the excess loss of fluid, you are going to have poor renal perfusion, which will lead to impaired excretion of the ketones and then the hydrogen ions. Because basically, once you have poor renal perfusion, remember what we talked about, acute kidney injury will come in, like pre-renal failure, which we discussed recently. So poor renal perfusion will lead to pre-renal failure. Pre-renal failure means that the kidneys will now fail and will be unable to get rid of ketone bodies and then the hydrogen ions. And so this will accumulate in the blood, and then it will decrease the pH. And once it's decreasing the pH, then you know that the blood becomes more acidic. And of course, even when you pour acid on your system externally, you know what happens. So once your blood becomes more acidic, or your pH falls, then it means you're going to have issues, because most of the enzymes or most of the processes that go on in your body are dependent on you having a normal physiological pH. Once your pH falls below 7.0, then this enzyme system will become inactive. The action of this enzyme system will reduce, and basically, gradually, you'll be singing "Draw Me Nearer Today" if we don't manage you properly. So are we okay with the pathogenesis? If you have any questions with the pathogenesis, I can quickly touch on it. Are we okay with that?
Yeah, so I'm okay.
Yes, sir.
Great.
I want to ask.
Yes, please.
When you are starving and your body makes use of the fat.
Okay.
And someone who is not diabetic. But if you are diabetic and it makes use of the fat, there's a problem. What's the difference? Like I'm not diabetic, I make use of the fat, there's no issue. But if you are diabetic and make use of the fat, is it because of the accumulation of the?
Oh, all right. Okay. So you're saying that if a non-diabetic makes use of ketone bodies, it's not an issue. But all right, okay, because you, the non-diabetic, the reason why you are actually making use of the fat as at that point, it's not because you have insulin deficiency. It's because your stores for glucose, maybe your carbohydrate stores, or maybe you are fasting for a while, so your sugar levels are depleted, and so you need to make glucose from new sources, or you need to try and produce energy from new sources, and that is what we call gluconeogenesis, trying to make glucose from new sources. So that is a natural process that comes in, and it's something that happens when you starve. Okay, so ideally for you, the normal person, when you are going through this process, it is not likely for you to develop ketone bodies. Why? Because you have insulin. So at that point where the new glucose stores are produced, your insulin that you have will regulate it and keep the sugar under control. Do you understand? Because you don't have insulin deficiency. So if you go and then you go and make use of your fat cells, the sugar levels that will start going up would be well controlled because you have normal level of insulin. But this diabetic here, the reason why this diabetic is going to have, going to attack the fat cells, it's not because there's no glucose, it's because the system feels there's no glucose. And this is because of the deficiency of insulin. So already there's blood glucose, but for you to go and attack your fat cells, it means you would have diminished blood glucose. So you'd actually be facing something like hypoglycemia before you go and make use of your fat cells. But this person already has some form of hyperglycemia, but the body is not making use of it.
Okay, thank you.
Does it make sense?
Yes, it does.
All right, great.
Hello, sir.
Yes, please.
Yeah, please. So, please, does it mean that the insulin will regulate the ketones that will be formed after the fat metabolism?
Can you take that again?
That please, does it mean that the insulin will be regulating the ketones that will be produced in somebody who is not a diabetic?
You said yes. In somebody who is not a diabetic, yes. So once it's not about the insulin regulating the ketones, the insulin will regulate the eventual action of these ketones. Because once you are making these ketone bodies, the action is that it's actually going to go through a cycle for you to make new sources of glucose, energy, ATP.
Okay.
You get it?
All right.
Yes. So sometimes, and that is why sometimes people have questions about, so what about those who do keto diet? Does it mean that when they starve themselves, it also has its own side effects, but technically it would usually not cause hyperglycemia because you already have the insulin to control. If you decide to do a keto diet, you have your insulin to control the level of the sugars once they start going up. But in this diabetic, already there's some form of hyperglycemia, and this is actually going to have an effect already because of the hyperglycemia. They're going to have the glycosuria, which would come with osmotic diuresis, and hence it's going to come with the dehydration and then the electrolyte imbalance. That's one problem already. Okay, and then because the system is not really feeling the sugar, they go ahead to try and make new source of energy, and then that will lead to the excess production of the ketone bodies. So there are two different pathways. In the normal person, this won't happen because they actually have insulin. They don't have insulin deficiency. And that is why, let's not even say in the normal person, in a diabetic who just has a little amount of insulin being produced, they would usually not have diabetic ketoacidosis because that insulin that they have would always prevent you from going to attack your fatty acids, glycerol to make ketone bodies, because at any point in time, even though your sugars will be going up, because you have some insulin, that insulin will push the sugars into your cells and hence you won't go into DKA. And that's why even before we started discussing DKA, we said that usually it's a disease. Once you have DKA, then clearly we start saying that you have some form of insulin deficiency. Are we okay with that?
Yes, sir. Thank you.
You're welcome.
Hello, sir.
Yes, please.
I know that when you have DM, there are some symptoms or signs that you can see. But last week, we lost a colleague because before she died, we realized the sugar was very high. We know she's hypertensive, but not about the sugar. Was there no sign, and the sugar couldn't be brought down, and she passed on?
Yeah, so you can see that before I even we even went to the pathophysiology. You can see my screen now, so you can see DKA usually presents in previously undiagnosed DM. There are a lot of people walking around who are DM that haven't been diagnosed. And the reason why this is so is that they won't show you the classic symptoms. Eventually, occasionally they'll say, oh, maybe they pee a little bit frequently. They might think it's a UTI, and most of the time, I mean, but all of us will agree that if you are taking a history and you ask a patient, do you urinate frequently? They go like, oh, I drink a lot of water, so I think that I urinate frequently. Most people would think that is it. The best way to know is regular screening. And the previous lecture, I said that even as clinicians, we should be doing that for ourselves. If we test and our sugars are fine, we should repeat in 6 months, because sometimes you can never know. Your patient would be asymptomatic, and then all of a sudden you go and do a BE inquiry and you realize that your EGFR is reduced, and we'll check your sugar, HbA1c, and we'll tell you you are diabetic. Not everybody would show the classic symptoms of polyuria, polydipsia, weight loss. Not everybody will show such classic symptoms.
Okay, Doc, thank you.
You're welcome. Evans, I think your hand is up. Yes.
Sir, I wanted to. Okay, so if, let's say, you were saying about the testing.
Yeah.
Doing the HbA1c and then doing the sugar. Doing chemistry, you realize that the glucose is showing very much, but then the blood might not really show that much.
Oh, yes. So
what's your view about that?
I agree with you. So our previous lecture, as part of investigations, I talked about a urine ARI and the importance of a urine ARI. The fact that one, it will rule out a urinary tract infection, and two, it will point to glucose in the urine for you to know that the patient is diabetic. Because yes, I've seen cases where they come to you and then you are able to pick up diabetes based on the urine ARI, and you ask them to do further investigation. So urine ARI is very, very essential for your diabetic patients. Okay. And sometimes you don't even...
And then my last question.
Yeah, sometimes you don't even need to do a classic urine ARI. Just the urine dipstick can pick sugar, and then it can point you to your diagnosis.
Yeah.
Okay. Yes, you said your other question.
What about long fast, like people who are on long fast, like long fasting? You said that the insulin helps to regulate the whole process of breaking down of the fats to provide the glucose neogenesis, to provide those energies that they need to keep going. So I want to get it clear that it's the insulin that does the job even in long fasting. Like if someone is practicing a long fast, like for hours, not eating,
okay,
like
so
it doesn't break like the normal fast that people do.
Yes. So our previous lecture, I said insulin does two things. The main one that we are aware of is that if you are just done eating and your blood sugar is high, your body should release insulin, and then it should push the insulin into the cells where it has to be used. Okay, that's the main one. The second one is when you are fasting or in the absence of sugar in the blood, insulin is supposed to orchestrate the process to help in some form of hepatic output of glucose. And in this case, insulin won't do it alone. Those other hormones like the glucagon and whatnot will also come in and cause you to make some sort of or produce some sort of sugar in the bloodstream. So yes, during fasting state, insulin does that, but it's not only insulin. The other hormones would also play a role.
Okay. Thank you very much, sir.
Okay, you're welcome. I think I'll take Evans, your last question, and then we can go on.
Yeah, so I realize sometimes when people have severe malaria, or let me say malaria, doctors used to request for urine RE, and ketones tend to show up. So I want to know what link does the malaria and ketones have in common, because
in common
it's happening both at times.
Okay, yeah. So one other thing that will let us see ketones in your urine is when you are dehydrated. Okay, when you are dehydrated, we would also see some form of ketones in your urine. So most conditions that will lead to vomiting, like malaria, like vomiting in pregnancy, like a severe urinary tract infection, once there's some form of dehydration in there, ketones would increase in your urine. We would end up seeing ketone bodies in your urine. So that is actually the link over there. Okay.
So say it's normal when you see a malaria patient.
So when you see it, and then you are worried, what you do is you check the blood sugar level. Okay, if it's just malaria and it's not a decay, blood sugar level will be fine. Most of the time, if you see it in managing of an infection, it's good to actually go ahead and then check the blood sugar level. Maybe you see ketones in the urine. Oh, wow, okay. But if you check and the sugar is fine, it's not surprising. It's because of the disease state or the infection, which is sort of predisposing the patient to that dehydration. And that is what is causing the ketones to appear in the urine. So sometimes you see kids and then you see ketones in their urine and all that, but they are not diabetics, but they come to you with some form of infection. And the mothers will tell you they've been vomiting and whatnot. That is the reason why. Okay. So we won't say that it's normal, no, but that doesn't mean that the person has decay. The ketones there is because the person has an infection which is precipitating or predisposing to some form of dehydration. Are you okay?
Thank you.
Welcome. Yes, that's a good question. So let's look at the clinical features. So similar to what you get in your diabetic. So as I said, they will be urinating a lot, okay? And then also they would end up drinking a lot of water. So that's the polyuria, polydipsia. Because of the whole process, we've already talked about the pathophysiology. There's going to be nausea, it's going to be vomiting because of the metabolic acidosis. And this would even worsen the acidosis because once you're vomiting, it leads to dehydration. And then you are going to develop some sort of renal impairment, which would lead to difficulty in your kidneys excreting this hydrogen ions and ketone bodies. They also tend to have severe abdominal pain. So sometimes people have been, people have missed DKAs and then have managed DKAs as acute surgical abdomens, like maybe an appendix or maybe an intestinal obstruction, but then you go and you do your investigation, you realize the patient has a DKA. DKAs can present with severe abdominal pain that the patient would be lying down, what we call prostration. Then their breathing, they tend to also have some sort of deep labored breathing, what we call Kussmaul's breathing, okay? Then there's confusion, there's stupor. In severe cases, they can have coma. And when they talk, they have this fruity breath, and this is due to acetone. The acetone is a type of ketone bodies. There are 3 types of ketone bodies. We have the acetone, we have acetoacetate, and then we have what we call beta hydroxybutyrate. I think it's in your slide. These are the 3 types of ketone bodies that we have. Then they can also have the features of shock. Okay. Investigations, of course, blood glucose levels will be raised. Kidney function tests, you can realize that your urea and creatinine levels will be deranged, electrolytes will be deranged when the patient is actually having some form of acute kidney injury. You can check for bicarbonate levels, and the bicarbonate, it's a base. So once you are talking about acidosis, then you mean bicarbonate levels will be reduced. Then you have to do a urine RE, which we've talked about already. You know the reason why you're doing the urine RE. You are looking out for ketone bodies, that's one. You are also looking out for the source of what is even causing the DKA. Remember, we said that stress of intercurrent illness. So if there's some bad urinary tract infection, which is causing a urosepsis or sepsis secondary to urinary tract infection, your urine RE will tell you. And that's one of the reasons why you need to do a full blood count also if you have any sepsis. Your arterial blood gases is very essential. Your blood culture, urine culture, all of this will point to an infection, because you would realize in your practice that most people who have DKAs have other medical conditions that has basically stressed and predisposed them to the DKA. For instance, someone can develop an MI, a myocardial infarction, and this MI would lead to a DKA because of the stress that comes with it. And that's why you can see ECG over there. Someone can have that, maybe a pneumonia and all that, so chest x-ray. Someone can have a stroke and actually develop a DKA if the person is a diabetic. Okay, so that's why you need to do all these investigations. The complications, we talked about dehydration, so this will basically lead to shock. So you can see the hypotension over there. Severe cases, they can have coma because of the whole pathophysiological process, and then the fluid retention and all that, because the kidney is failing and all that. They can also develop some form of cerebral edema. They can have hypothermia because they will be, they are going to be admitted. Sometimes they can develop a DVT. They can develop a pulmonary embolism from this DVT. They can develop a pneumonia. These are least complications that will usually arise when they are on admission. And then through your treatments, you can end up rendering the patient hypoglycemic if you don't really take care and you are managing and you are giving insulin without checking. Your patient can become hypoglycemic. Also, your treatment can make the patient hypokalemic. Why? Because when you are managing, you remember when we were managing AKI, and we said that when we want to control, is able to force potassium into cells. So insulin levels can regulate potassium. That's the same principle here. When you are giving your insulin in managing your DKA, indirectly, this insulin you are giving to control the sugar would also have an effect on the potassium, and it's going to force potassium into cells. So even though you are managing to regulate blood glucose, you can end up developing hypokalemia, because your insulin you are giving is not only going to control blood glucose, but will also have an effect on potassium in the blood. So whenever you are managing, we want to be careful, and we want to be monitoring the potassium levels regularly. And then, if possible, we add potassium to our treatments just to prevent hypokalemia. And mind you, once the kidney fails too, there's a risk of hyperkalemia. So managing potassium levels during DKA, you really need to be cautious, because the DKA itself and the shock and everything can lead to hyperkalemia. If you rush and you go and give potassium because you think you're going to give insulin, you end up developing hyperkalemia, which can cause arrhythmias and kill your patients. If you fail to give potassium and you give only insulin, you end up developing hypokalemia, which can also lead to arrhythmias, which can kill your patient. So in terms of insulin, it's a tight balance. It's a tight balance when you are looking at potassium. And then, of course, pulmonary edema would also be a complication because you'll be giving this patient IV fluid and you can end up flooding the chest. So the aims of management for a DKA is straightforward. Because of the shock, you want to do fluid resuscitation. That's one. You want to reverse the acidosis and the ketosis. You want to reduce the blood glucose level. Also, you want to make sure you are replacing the electrolytes that are lost. Okay. And you want to identify the underlying cause. So if you know these 5 things, if you are asleep and I wake you up, DK, what do you have to do? Oh, I need to give IV fluids. All right. Okay. The next thing is I want to make sure that this acidosis has been resolved. I want to make sure the sugar level has been controlled. I want to make sure that the electrolytes are balanced. And then I want to find the source. What is causing the DK? Is it an infection? Is it that the patient failed to take the insulin? Is it that this patient has some form of MI? That is the 5th thing you do. And once you know this thing, management becomes easier. So the first one we are looking at is fluid resuscitation. So once the patient comes, you set your line, you're giving your patient IV fluid. So preferably we like Ringer's lactate or normal saline. You give your patient about 1 to 3 liters in the first hour. Then in the second hour, you are giving about 1 liter. Then you are giving another 1 liter following the what you gave in the second hour. And then after every 4 to 6 hours, you are giving 1 liter. Okay, so it's just a protocol. And most facilities have their protocols pasted on the wall, but this is one of the accepted protocols when it comes to infusion. So 1 liter or 1 to 3 liters within 1 hour, depending on the shock state, because some DKAs will come, you realize that the BP is not so bad. So you can give 1 liter in 30 minutes. But usually, depending on the shock state, you are doing about 1 to 3 liters in 1 hour. Then in the next hour, you are giving another 1 liter to run within 1 hour. Then afterwards, after 2 hours, you are giving another 1 liter. Then afterwards, after every 4 to 6 hours, you are giving 1 liter. Okay, that's how you do it. Then now you need to control the sugar, and we do this by giving insulin. In our previous lecture, I told you we give short-acting insulin. That is what we would give to this patient. So the short-acting insulin here, we don't want to give long-acting because it takes a long time to act, and when it starts acting, regulating it becomes difficult. But short-acting will act very fast, and you can always check your sugar level in an hour and then adjust the dose. Okay, so you can only start your insulin after you've started your IV fluid. Sometimes people are in a rush to start insulin, but make sure you've hydrated your patient. In some cases, you might need to start your insulin, especially if your patient has an acute left ventricular failure, the heart is failing, and this has also triggered a DKA. These are the medical dilemmas that you'll be facing when you are practicing full time. A patient can come to you, listen to the chest, there are crepitations all over, meaning there's fluid in the chest, and the patient's sugar too is over the roof. The patient has a DKA. What will you do as a clinician? We are saying give fluid, so what are you going to do? So in this case, then it should be a tight balance. You let fluids go slowly, but your main aim of reducing the sugar would be giving your insulin rather than pumping a lot of fluids. Okay, so those are the exceptions, but usually you need to resuscitate the patient and then give your insulin. And this is the dose of insulin you give. And you are giving about 0.1 units per kilogram per hour. Okay, so meaning if you have a normal adult weight of maybe about 70 kg, then 0.1 times 70 is what, 7 units. Okay, then it means that you are going to give your patient 7 units of insulin every hour. Okay, but of course, it's a range. So some people, some of the literature will tell you that give about 0.07 to 0.1 units per kg per hour. Okay, but to make it easier, we are saying administer IV soluble insulin at doses of 0.1 units per kg per hour. So you just multiply the weight by 0.1, and then that is what you are going to give every hour. And mind you, before you go to give this insulin every hour, and you are giving this insulin IV, one of the mistakes most of our healthcare professionals do in an emergency setting where sugar is high is you tell the nurse to go and give the insulin in a patient who has hyperglycemia, and then they go and give subcuts whilst you are trying to bring the sugars down in an emergency setting like a DKA. No, we will do subcuts later. At this point, because we want to get it down, we do IV. So always make sure they are giving the insulin IV. And every hour before they go and give the insulin, you need to make sure they've checked the sugars, because if you go and you are going to give the insulin and then the sugar is less than 11.1, you need to stop the IV soluble insulin. As you can see, stop the IV soluble insulin. And also, if they are checking and then you realize that sugar levels have come to about 13, then you need to stop giving your normal saline and then look at giving a dextrose containing fluid like DNS. Otherwise, your patient will go into hypoglycemia. Okay. The third thing we talked about is electrolyte imbalance, and I've already spoken about potassium. So you need to check your BE and creatinine. You need to check your potassium levels, and then you administer potassium accordingly. If your potassium is less than, as you can see, 6 millimoles per liter, then you know whilst you go ahead to give insulin, these levels will drop. So you have to start making plans to administer potassium. If they come and then as soon as you check potassium, you are getting values less than 3.5. Potassium level is about, normal is about 3.5 to about 5, they're about 5.5. You're getting values less than 3.5. Then it means this patient is actually hypokalemic, and you have to think of giving some sort of potassium. Okay, so you can see that in severe hypokalemia, delay insulin infusion and administer 20 to 40 millimoles of potassium chloride during your IV fluid, as you can see. So in severe hypokalemia, don't be in a rush to go and give insulin, because when you give, it will make your hypokalemia worse. It will push the rest of the potassium in the blood more into the cells, and this hypokalemia would become even more severe. Arrhythmias will occur and patients will die. And this is one thing we don't do in our clinical settings in terms of checking your electrolyte. Because even if you request for BE and creatinine, it will take a long time to come and all that. We just manage. It's bad practice. If you have access to your electrolytes, BE and creatinine and all that, it helps you make a good judgment on when to administer insulin or not. Because insulin can be life-saving in reducing your sugars, but also it can be a death sentence by causing you to be hypokalemic. So we need to be careful. Then sometimes, not always, but if you have bicarbonate and then the acidosis, ahead and then administer some bicarbonate. As you can see, I said bicarbonate is basic, so 500 mils of 1.26% sodium bicarbonate. We usually don't do it, but it's something that can be done, and it helps in the acidosis. But the thing is that most of the time, the acidosis will correct itself when you are giving enough fluids, you are giving insulin, and then you are controlling your electrolytes. And then the last one, you have to treat the whatever is causing the problem. If it's an MI, you treat it. MI means myocardial infarction. If it's an infection, you treat the infection as such. Okay. If it's an infection, then you want to start with empiric treatment whilst you take samples for your culture and sensitivity. So that is DKA. I think I'll take 2 questions, then we'll quickly go through the other aspects of hyperglycemia because time is fast spent. So any questions, please, on DKA management?
Hello, sir. Please, how will you administer the KCL? Is it you add it to the normal saline or direct?
Okay, so it's good to add it to the fluid so that you can be able to control how you give it. Because if you want to give something like maybe you say, okay, you want to give 20 millimoles of potassium chloride every 8 hours. Okay. If giving it as a bolus, you are also worried about the heart. So it's good to give it slowly. So you calculate and put it in the infusion, and then you use your dosiflow to regulate, and then you let it go throughout. It's better that way to put it in the infusion than to give it as a bolus.
Thank you, sir.
You're welcome.
Hello, sir. Please, normally, throughout my work experience, when you get patient with sugar level from 20 and above, sometimes 30, we normally give insulin 10 unit IM, 10 unit IV. Is there something wrong about that?
Okay. So as I said, that there are different protocols that people follow. When you go to their facilities, there are different approaches to managing the sugars. Sometimes when the sugar is that high, and people will say 10 IM, 10 IV, especially when they come and the sugar level is above 33.3. That one means that it's gone above that. You don't even know what the value is, but you know it's above 33.3. So sometimes going to do that 0.1 units per kg per hour might take a very long time. So some people will decide to give a start dose of 10 IV, 10 IM, and then they wait for 1 hour, and then they check if by then the sugar has fallen below 33.3, then they can go ahead and calculate with the dosing over there. So it is done. But sometimes the patient comes and then the sugar is high, but you know how high it is. It's like maybe 24. If you go and give 10 IV, 10 IM, you might end up crashing the sugar and the patient will go into hypo. So it's good to start gradually. So that technique, I know people use it, but it comes in play when your sugar is high, very high, above 33.3. That's the machine can't record. Then you give that, then you recheck in an hour, and then afterwards you come and follow this protocol. You get what I'm saying?
All right.
Yeah.
Thank you, sir.
You're welcome. So let's look at HHS. It's straightforward. Okay. Remember in DK, we said that primarily it's a disease of insulin deficiency. So once there's no insulin, then it means that the sugars will stay in the blood. Your body won't recognize the sugars, and hence you have to go to break down your fatty acids, and then you make the ketone bodies. Okay. But in HHS, usually there's insulin, as I said, and this insulin activity is enough to prevent you from going to cause ketogenesis. You understand? So once you have just a little level of insulin, this ketogenesis won't even happen in the first place. And that's why I was answering the other question by saying that those who fast and all that, and then when ketone bodies come in play, because of the insulin level, sometimes it even prevents the fact that you have insulin. It comes in play, and it even inhibits that excess ketogenesis for you to have a lot of ketone bodies being produced and metabolic acidosis. So for HHS, there's some level of insulin, and once you have that level of insulin, you know that it's actually going to inhibit you from making excess ketone bodies, and so you are safe from DKA. However, you are not safe from the other complications we'll be looking at shortly. So they're saying that HHS, or hyperosmolar hyperglycemic states, will present with very high levels of sugar. In fact, usually the sugars can be even higher than the level of DKA. Usually the sugars are about 33.3. Okay. And also there's hyperosmolarity. Because of that high sugar, the blood becomes very hyperosmolar. Okay. But then there's actually no ketoacidosis, or there's insignificant ketoacidosis because you have some level of insulin. So in this patient, the issue is more of insulin resistance than what insulin deficiency. Okay, so usually patients who present in the middle or later life, who have a history, basically we haven't told them they are diabetics. So your type 2 DMs who maybe poor lifestyle modification and whatnot, then they just rush them in and you check and it's high, and that'll be the first time they'll be told they have diabetes. Okay. So these are the diagnostic features. Once you want to make a diagnosis of HHS, the sugar level should be above 33.3. And if you're able to check osmolarity, it should be above 320 milliosmoles per kg. And usually because of this high osmolarity and sugar levels, the dehydration is serious. And all that, okay? And sometimes we'll be vomiting because of the high sugar levels. And in this case, the pH is actually not below 7. The pH is above 7.3. Bicarbonate levels above 15 millimoles. And there's actually small level of ketone bodies in the urine. And sometimes there's actually no ketone bodies in the blood at all. And they have an altered mental state. Okay, so that's the diagnostic features. And usually when you're diabetic, you don't know you're diabetic, or you know, and you eat glucose-rich fluids, and you're taking glucose-rich fluids or you eat glucose-rich foods, then you're at risk. If you're on thiazide diuretics like the Benadryl, if you are using medications, steroid medications like dexamethasone and all that, you can develop HHS. So maybe you have a patient who has COVID who is on dexamethasone, you realize that sugar levels can go up, and also intercurrent illness. The features are somewhat similar, but in this case, you don't have that classic fruity smell that you get in DKA. You don't have that severe abdominal pain, but you are going to have nausea, vomiting, polyuria, polydipsia, and then you have shock, okay? And then, of course, the shock can cause an altered mental state. Investigations, you can check your serum glucose, you can check your BE and creatinine, you can do your ABGs, material blood gases, you can do a full blood count, you're looking out for infection, urinary, urine, CS infection, chest x-ray, you want to rule out an infection or pneumonia, maybe there's a problem, head CT scan, all of this will help you. You can also calculate the serum osmolarity by using the formula. You are looking at this formula where you are adding sodium and potassium and multiplying by 2, a product of that, and then you're adding that to the glucose and then the urea level. And once you do that and you're getting values above 290, then it means that the osmolarity is basically going up, so you need to be careful. Okay, so 2 brackets N plus K, that's sodium and potassium, bracket close, plus glucose plus urea would help you calculate your serum osmolarity. Management is straightforward. Because the patient is dehydrated, you have to rehydrate vigorously. Okay, so you give your normal saline, you try and replace. Of course, you need to pass a catheter, and you do the same thing for a DKA, because the catheter will help you know whether your patient is making urine or not, and you can measure the urine output, and that would help you know that, okay, this patient actually has a kidney problem, an acute kidney injury or not. Okay. So you need to rehydrate. So don't forget to pass your catheter when you are rehydrating, so that you can monitor your urine output. And then you need to correct the hyperglycemia by giving insulin as similar to the dose we give in DKA, so 0.1 units per kg, and then you treat the underlying illness. Of course, because you are giving insulin, you also have to monitor your electrolytes in this case. So the management is somewhat similar, but the presentations are a little bit different, because DKA, you might have that classic fruity smell, but HHS, you won't have that. And you need to be more aggressive in terms of your fluid resuscitation when you have HHS, okay, because they would have lost a lot of fluid. But of course, as I always say, make sure you listen to the chest when you rehydrate, so that you don't end up flooding your patient's chest. In the past, we've seen patients with dilated cardiomyopathies, meaning the heart is unable to contract, and these patients are also diabetics. They come with increased sugar levels, and because you fail to listen to the chest, we end up killing this patient, and we say, oh, they died because of the sickness. No, they died because of mismanagement. We always need to be careful when we are doing aggressive resuscitation. Catheter in, you're listening to the chest, you are monitoring urine output, you are listening to the chest, just to be sure you are not overhydrating your patient, and just to be sure your kidneys are making enough urine. Okay, so straightforward. I think I can take questions here, and then we can take a look at one more topic, and then we close for today.
Hello, sir.
Yes, please.
Yeah, please. I've been seeing this condition throughout my practice. I don't know whether it's because of I'm working at a lower level. Okay. I've not seen any patient being diagnosed like this. It's always hyperglycemia and diabetes or diabetic ketoacidosis. Is this something people normally miss? Is there any classic thing we can see if
with the HHS?
Yes, please.
Yes.
Is there anything we can see if there's a person here who is DKA, another person HHS? What is the classic thing? Because for the ketoacidosis, at least we know of the Cosmo breath, the acetone breath. Normally they have
then the ketone bodies in the urine and all that.
And those.
Yes, your HHS can also come in an unconscious state. So at least with the DKA, you know the classic features. With the HHS, those classic features in DKA will be missing. So that will draw your attention to the fact that, okay, this is not a DKA, but the sugar levels is very high, especially the first time I checked my sugar was about 33.3. I gave you a slide on diagnostic features, you can see. So at least, okay, blood glucose above 33.3, that should point you to a certain direction. Then you can come and calculate your serum osmolarity by the formula that I gave you. Once your BE and creatinine comes and then the blood glucose comes, you use that to calculate the serum osmolarity.
All right.
Are you okay? So that's once you calculate and then you are getting a serum osmolarity greater than what the diagnostic feature is saying, then it means that, okay, this is looking like an HHS. And your history will also tell you, especially if they tell you the patient has been vomiting so many times, or patient comes and then you make a diagnosis of severe dehydration, then you know that most likely with severe dehydration, blood glucose greater than 33.3 without ketone bodies, this is HHS. Okay. So you have to make a conscious effort to diagnose. When I was doing my medicine rotation at Tema General, we, the house officers at that time, we made a conscious effort to write HHS because there's a tendency to just write hyperglycemia in a diabetic. But because it was a learning process for us, we made a conscious effort. So we ask, okay, what was the sugar when it came? Oh, 33.3. All right, okay, so most likely ketone bodies, no ketone bodies, then we are confident and we can say, okay, let's wait for BE and creatinine. We calculate serum osmolarity. Oh, this is HHS, then we put it there. So it was a constant effort. You have to put in that constant effort, okay, to make that diagnosis.
Thank you.
You're welcome. So I think we can break here. Yes, please.
Hello, sir.
Yes.
Yes, sir. With the DM, if I can get you right, we are talking about those that the insulin, they are not producing it at all, or those whose body is producing, but the organs can use them. Do you have any class who's are having problem with both, that their body is not producing and their organs too are not also seeing it at the same time in other people too? Do you have?
So if your body is not producing, the organ will definitely not feel anything because you don't even have it at all.
Yes, sir.
Do you get it?
Yes.
So that is the type 1. So your body is actually not making the insulin at all. So there's no way the organ will even recognize the presence of the insulin. But then there are also the class, the type 2, where the body is making some insulin, but then the receptors for the insulin are failing to recognize the presence of the insulin. And that's the type 2, what we also call insulin resistant diabetes. But of course, this type 2, as I said, eventually, when they have it for some time, the kidneys, the liver would, the pancreas would get tired, and eventually the beta cells of the pancreas would get tired and it would stop making insulin for even this type 2 diabetics who were initially making some insulin, insulin resistance, and eventually it will also not make them at all.
Oh, okay.
Yes.
Okay.
Hello, sir.
Yes, please.
Please, I want to ask why you said that thiazide diuretics can also increase the glucose level.
Okay, so basically, once you are taking thiazide diuretics, it sort of precipitates glucose. Thiazide diuretics will get rid of excess fluid, and in getting rid of that excess fluid, it would leave the sugars behind, so it will precipitate the glucose in the bloodstream, and hence your sugars will go up. Basically, that's like the easy way to understand it. So it's like you are getting rid of fluids, okay, but then it leaves behind the sugars. So that's one of the side effects of thiazide diuretics. It precipitates and then it causes some form of hyperglycemia.
Oh, okay. Thank you, sir.
You're welcome. Because should I put it this way? Mind you, if you think about it this way, it makes it easier. If you have a jar full of water, and then you have maybe about 1 liter of water in a jar, and you have 1 teaspoon or 1 tablespoon of sugar in this 1 liter, and then you have about 200 mils of water, and you have the same 1 tablespoon of sugar, which one would taste more sugary? Hello?
The one with less water.
Exactly. So you get a principle.
Concentrated in
so that is the same principle. So with the thiazide, because it's causing you to lose more water, the system is sort of water deprived. So the sugar there in the diabetic will be a little bit, in quotes, hyper. So the system would feel it that way. So it precipitates the sugar because you are losing water without sugar. Do you get it? Do you get the principle then?
I think that it almost looks like a concentrated system.
Exactly.
The water, you are losing the fluid, but it's retaining the minerals or
exactly.
the sugars and other things behind.
Yes, so that is the reason why. Okay, great. So let's take about 5 minutes. So Nick, I think you can probably end this one, and then we put up the new one. So take about 5 minutes break, and then we quickly come, because it's a new topic altogether. So I just want us to get our minds ready for it. Maybe we might be able to finish that today, or we'll continue that one tomorrow. But I want us to at least start something and then do something till like 8. Oh, we are not here. All right. So
let's continue.
Yes. So let's look at thyroid diseases. It's quite straightforward. I'm sure in our basic sciences, physiology, anatomy, we all know what a thyroid gland is and what it does. We'll be looking at some diseases of the thyroid gland in terms of internal medicine. The common ones that you see in practice, and some of the things that you should know to help you make such diagnosis and to help you manage such patients. You might not be seeing it so many times routinely in the clinics, but there are cases out there that will come to you. And when they come, the whole world is dependent on you that to be able to make a good diagnosis, start management, and then refer to the endocrinologist to take over. So basically, in terms of thyroid diseases, we'll be looking at conditions that basically would arise because the thyroid gland is overreactive and making excessive hormones. As we know, the thyroid gland makes hormones, tyrosine and triiodothyronine, or T3 and T4. So we'll be looking at conditions where you have excess production of your thyroid hormones, and also we'll be looking at conditions where you have diminished production of thyroid hormones. And so that's the outline. So we'll just take a look at it, and then hopefully we should be able to discuss the most. So this is just a brief summary, or should I say a recap, or should I say a revision, just to take our minds back on what the thyroid gland actually is. And for those of us who have forgotten, I'll try and see if I can show a picture right away from the internet. So you can see that the thyroid gland actually is consists of two lobes, and it's connected in the middle by what we call the isthmus, and the gland is firmly attached to the thyroid cartilage. So usually when you swallow, it moves up and down. Okay. Then blood supply. This is for those of us interested in anatomy. It has a very rich blood supply, and you should know that, because if you make a diagnosis and then it's something relating to the thyroid and it needs to be surgically taken out, we are always careful because of its extensive vascular supply. Okay. You can see the superior and inferior thyroid arteries. In terms of still anatomy and some physiology, when you go into or you cut open the gland, you see what we call follicles, and the follicles are lined by special cells called cuboidal epithelial cells. And inside these follicles, you have a solution or a glycoprotein or a substance in there that makes hormones, and this substance is called a thyroglobulin. So through a series of processes, this thyroglobulin and all that goes through processes where you have what we call iodine trapping and the conversion. It goes on and on and on, and then you end up making your T4 and your T3. That's physiology. I won't go into details, but basically your thyroid gland makes this T4 and T3 from the follicles. Okay. And then in the cellular level, or at the cellular level, we say the T3 is more active than the T4. Okay. And then in the plasma, we say that more than 99% of all T4 and T3 is bound to what we call the hormone binding proteins. Okay. Let's see if usually once you see a picture, it makes things stick and it makes learning easier. Can you see my screen?
Yes, sir.
Yes, sir.
Okay.
Yes.
Okay. So you can see the thyroid gland and all that.
No, sir.
No.
Okay. Okay. What about now?
Okay.
All
Yes,
down.
sir.
Yes.
We can see.
Yes.
So basically you can see the thyroid gland
Yeah.
here. And that's the same thing
Not
here.
yet.
So you can see the lobes. These are the lobes we talked about. The right, the left, and is connected in the middle by the isthmus. If we go up, you can see the vessels we talked about. Okay, so you can see this is the superior thyroid artery, which comes all the way here. There's also an inferior thyroid artery, which comes from there. So basically, this is how the gland looks. Okay, this is how it looks. We will come to this picture in a bit. We'll come to it in a bit. So when you cut into the thyroid gland, as I said, you can see this is like the histology. So let's look at this picture. I don't know why my thing is failing to expand.
Doc, you might have to probably download the image and then open it. I think it's the resolution that's making it that way.
Yeah, I actually wanted to expand my screen, but I don't know why.
Okay.
I think you can see it now, right?
Yeah, it's quite visible.
So this is the gland. And when you go into the gland, this is what you find. So this is what we mean by follicle. So you can see this whole round thing here is a follicle, okay? This whole round thing here is a follicle. And inside this follicle is what we call the colloid. And the colloid is what the thyroglobin that we talked about. So this is like a protein substance that the system usually would use that to make the hormone. So you can see something like this. So you see, this is like the actual histology. So this is a follicle, and the follicle is lined by cuboidal cells nicely, and inside there is the colloid or the thyroglobin. So this is what I've been trying to show you. So we'll come back to pictures again. Okay, can you see my new screen now? Can you see it now?
Yes.
Yes, sir.
All right, great.
Yeah.
So now you have a picture of what we're trying to talk about when we're looking at the anatomy. So it's always good to have that picture. So you're saying that inside the follicle, or where the colloid is, you have this substance, the thyroglobin, in there, and it's needed for thyroid hormone synthesis. And in making thyroid hormones, we are looking at three things. We are looking at T4 and T3. Okay, so we've already gone through this. So in terms of pathology, there are two main types. You can have underactivity of the thyroid hormone, meaning the thyroid hormone isn't making enough. Underactivity of the thyroid gland, meaning the thyroid gland isn't making enough thyroid hormones, what we call hypothyroidism. And we can have overactivity of the thyroid gland, which means that the thyroid gland is making excess thyroid hormone, what we call hyperthyroidism, talking about today. So let's look at hypothyroidism. But before we look at hypothyroidism, let's quickly go back to our pictures, and then I just want us to get something briefly. Okay, can you see my new screen, which I'm sharing now?
Yes, sir.
Yes.
Yes,
Great, great. So for you to be able to understand this well, I'm sure we all know this, but it's always good to, come back to it, and then it gives us a reminder of what we are actually talking about. So there's an axis basically which regulates thyroid hormone synthesis and then production. Okay, so if let's look at this picture here first. So you can see the schematic diagram is giving us something, and we can see hypothalamus, anterior pituitary, we can see thyroid gland, and we can see target tissues. Okay, the whole synthesis and then the regulation pathway is dependent on these four things. Okay, as you can see, you need basically you need four things in this pathway. One is the thyroid releasing hormone, which is what we call the TRH, which you can see as I'm pointing to. Then there's a thyroid stimulating hormone, which is called the TSH, which is what I'm pointing to now. Then there's the T4 or the thyroxine, and then there's the T3, the triiodothyronine. Okay, and sometimes there's what we call reverse T3, which we'll be looking at. So basically, for you to be able to make T4 and T3, the hypothalamus should produce the thyroid releasing hormone. They should come and act on the anterior pituitary to stimulate it to make thyroid stimulating hormone. And then this thyroid stimulating hormone, as the name suggests, should come and then act here, and then would help you make your T4 and your T3. Okay, so it's like a pathway. And once you have made T4 and T3, then this, as you can see, this T3, once the levels go up and you have enough, it's able to exert what we call a negative feedback on the anterior pituitary, and it tells it that, hey, we have enough T4 and T3, so do not make any more TSH. So the anterior pituitary also gets this feedback and stop making TSH, and then we are okay. For a pathology to happen, it means that clearly, as you've seen this, the the pathology can either be from the thyroid gland or it can be from the brain, where you are looking at hypothalamus and anterior pituitary. What am I saying? If your thyroid gland has a problem, okay, you can have the brain functioning well in terms of your hypothalamic pituitary axis. You are making enough TRH and TSH, but then it's stimulating the thyroid gland, but the thyroid gland is not functioning well. So the thyroid gland is unable to make your T4 and your T3. So you can see that this is clearly a pathology of the thyroid gland. So we call this a primary thyroid disease. Also, you can have a normal thyroid gland, but then because the patient has a problem with the hypothalamic pituitary axis, maybe there's a tumor sitting here somewhere, this tumor or whatever the problem is going to impair the production of this TRH, TSH pathway, and hence the thyroid gland won't be stimulated, and so you'll be unable to make thyroid hormones. When this happens, this will be called what? A secondary thyroid disease. It means the thyroid gland itself is fine, but then the issue is coming from above the thyroid gland because you are not making TRH or you are not making TSH. Are we okay with that principle? So, yes, issues of decreased thyroid hormone or increased thyroid hormone synthesis can either be due to a problem with the thyroid gland, or it can be due to a problem with the brain, your hypothalamic pituitary axis. If it's a problem with the thyroid gland, then we say it's a primary thyroid disease, so a primary hypothyroidism or a primary hyperthyroidism. If it is a disease that is above the thyroid gland, then this becomes what? A secondary hypothyroidism or a secondary hyperthyroidism. For instance, you can have excess production of thyroid stimulating hormones, okay? And this excess production is going to continually stimulate the thyroid gland to make excess thyroid hormones T3 and T4. In this case, the problem is actually not from the thyroid gland, but the problem is probably from something here which is making excess TSH and is stimulating the gland to make too much T3 and T4. And so even feedback, negative feedback here is not working. It's still making more. So even though this will become hyperthyroidism, this will become what? A secondary hyperthyroidism. Okay. And then you can actually have the thyroid gland itself going haywire and making excess thyroid hormones, which becomes what? A primary hyperthyroidism. Are you okay with this explanation?
Yes, sir.
Great. So this is another picture basically. So you can see the hypothalamus here, and this is the pituitary, which is ideally supposed to be under the hypothalamus here. And then this is the thyroid. So it's a cycle that involves three things. The hypothalamus is making TRH. The TRH will come and then stimulate your anterior pituitary. Anterior pituitary will now make TSH, and then your TSH will come and stimulate your thyroid gland, which will lead towards T3 production and T4 production. Once you have enough T3 and T4 production, this T3 is going to have a negative feedback on your anterior pituitary and tell the anterior pituitary, stop making TSH. This T4 is going to have a negative feedback on your hypothalamus and it'll tell the hypothalamus, stop making TRH. And in so doing, you don't have excess T3 and T4. But whenever this feedback is breached, then it means regulation of thyroid hormones become a problem. So basically, whatever we'll be discussing from here is dependent on this pathway. Are we okay? Can we go on?
Yes, Doc.
All right, okay, great. So you can see my screen now.
Yes.
Yes, sir.
Yes.
Okay. All right. So now let's take it one after the other. So hypothyroidism. This is we're saying it's a common endocrine disorder, and basically results in deficiency of thyroid hormone. So when you have the patient, what will let you know that the patient is hypothyroid is one, then levels of T3, T4 will be low, and then you can say the patient is hypothyroid. That's the first thing. And then afterwards, the onus lies on you to try. And afterwards, the onus lies on you to try and then say, okay, this is hypothyroidism and it's because of the thyroid gland, or this is hypothyroidism and it's resulting from the hypothalamic pituitary axis. Okay, the main thing is to be able to make diagnosis of hypothyroidism. So we say that it is usually primary. So as I said, a thyroid disease, or maybe secondary, a disease of the hypothalamic pituitary axis, which we've gone through. So in terms of etiology, as in what will lead to this hypothyroidism, hormones. So kindly go back to your physiology and revise how thyroid hormones are made. Iodine plays an essential factor, and that's why when we're young, we always say eat iodinated salt. If you don't eat iodinated salt, you develop goiter. We are trying to say that when you don't take in iodine, then it means that your body is not going to make enough thyroid hormone. So as a compensatory mechanism, because you're not making enough thyroid hormones, your TRH and your TSH would have an effect on the thyroid gland and to cause it to make more thyroid hormones. And in so doing, it will cause it to become hypertrophied and you develop a goiter. Okay, as we go on, you realize that goiter, if you have a goiter, it doesn't mean that you are hypothyroid. It doesn't mean you are hyperthyroid. It can be for both. Goiter is not a disease. Goiter is, as I always say, it's like a clinical feature of a disease. You understand? So goiter is not a disease. It's a clinical feature of a disease. It's the sign of a disease. Okay. So as you can see, iodine deficiency. So once iodine level goes down, clearly you need iodine to make thyroid hormone. So if you are deficient, then you make thyroid hormones. Okay, so that is primary hypothyroidism there. And sometimes you can have what we call atrophic hypothyroidism, where you might have some form of autoimmune disease, which causes your thyroid gland to shrink. And once your thyroid gland shrinks, you can't make enough thyroid hormones. Sometimes you can have some autoimmune condition where you have autoantibodies being directed towards some of the enzymes that are needed in making thyroid hormones. And that's why I say, try and revise your thyroid hormone production. You realize there's an enzyme called thyroid peroxidase. It's very essential in making thyroid hormones. Once you have some antibodies being directed towards this thyroid peroxidase, it would basically cause or lead to a defunct production of your thyroid hormones, and you are going to have issues there. Sometimes people deliver and they develop what is called postpartum thyroiditis. After they deliver, or sometimes in the pregnant state, their thyroid gland becomes inflamed. Okay, and there's also what we call the dyshomogenesis. So try and then, as I said, read about the whole process of making thyroid hormones. Okay, and then just go through these features and you'll be fine. Okay.
Okay, Doc.
Okay.
Hello, Doc.
Yes, please.
Please, so when one is developing goiter, the basic investigation you have to do is to check the thyroid first, the hormones. I'm referring to
check the level, to check the level of the hormones before you can know why the person is developing the goiter. You can't just look at the goiter and say, hey, hypothyroidism. No, you have to check the level of the hormones. As we go ahead, you would see once, for instance, since you're on hypothyroidism, let me touch on it again. So in hypothyroid patients, because the gland is not making thyroid hormones, okay, your TSH would be deprived of that negative feedback. You know that what stops the TSH from functioning, as we saw from the diagram, is a negative feedback, okay, from your T3. Because you are not making your T3, there will be the impairment of negative feedback. So your TSH level will keep going up. And this TSH level, what it does is that it causes hypertrophy and then hyperplasia of the thyroid gland. It causes, once it keeps going up, it will cause the gland to become big, because it's like, I'm stimulating you to make thyroid hormones. So I'll keep stimulating you until you make thyroid hormones. And in this case, it will lead to the development of a goiter. So you can see that it's not everything that is big is productive. So you see the gland there very huge, but then it's actually not making any hormones at all. It's huge because it has been overstimulated by the thyroid stimulating hormone, just because it's unable to make thyroid hormones. Do you understand that?
Yes, please.
Great, great.
Okay.
So the dyshomogenesis, basically, some people are born with a congenital issue there, and they are unable to make hormones. Some people too are born without a thyroid gland, and people just have a very tiny bit of thyroid gland. Okay, so we should always be grateful when we wake up every morning, because we could have been born with anything and we'll be having such issues. You can also have inflammation due to infection, subacute thyroiditis. Some medications like lithium and amiodarone can actually cause what we call hypothyroidism. If you look at amiodarone, it can actually cause hypo and then hyper. Okay, amiodarone, when you take it for some time, has this effect of destroying the thyroid gland, and when it destroys the thyroid gland, definitely you develop hypothyroidism. So that's like the long-term effect of amiodarone. But the short-term effect of amiodarone, because amiodarone has some effect on iodine, as the name you can see, actually you can see iodine in amiodarone. When you take it, it tends to increase your iodine levels to a certain point in the initial phase. So that can give you hyperthyroidism. But eventually, when you overtake it, it will destroy your thyroid gland and you develop hypothyroidism. Also, in the process of destroying the thyroid gland, it causes a release of the thyroid hormones into the bloodstream. So the thyroid hormones will go up. So amiodarone can do both. If you have a patient who is taking higher doses of antithyroid hormones like carbimazole, propylthiouracil, so clearly this patient would go beyond euthyroid. Euthyroid means that normal thyroid hormone level. So go beyond euthyroid to a hypothyroid state because of the higher doses of the antithyroid medications that he's taking. So what are the clinical features? Basically, people who have hypothyroidism, we are saying the thyroid hormones, as we all know in physiology, is responsible for what? The metabolism and all that, is responsible for activity, physical activity, mental activity. It makes you on point, it makes you sharp. So once you lack this hormone, you basically become slow. Everything would slow down for you. Okay, so these people tend to become slow. They have reduced mental alertness. Classic sign, they have what we call cold intolerance. They enter a place where the place is very hot, or you can pour hot water on them, but they still feel cold. Okay, so hypothyroidism, they have cold intolerance, they have weight gain, the skin looks dry, sparse hair, and all that. And of course, we've talked about goiter and why they will get goiter. Okay. They are always tired, there's loss of energy, they have constipation, they are depressed. When they talk, their voice is deep, their heart rate is slow. In terms of their menses is sometimes irregular, and then they tend to bleed a lot. Okay, what they have menorrhagia, so they tend to bleed a lot. So these are the clinical features. So when they come and you take their history, always try and ask for cold intolerance. If the place is hot, they'll tell you they are feeling cold. So you always try and ask, and then afterwards you ask the other features, and then your diagnostic laboratory of going ahead to do a thyroid function test will come and point to a reduced level of T3 and T4. Okay, so you can see your investigation, you are checking your TSH levels, you are checking your serum levels of T4, which will be reduced. You are looking out for your full blood count, liver function test. Sometimes they have what we call elevation in the transaminases. So as the AST, ALT will go up. So you always need to check. And then their creatinine levels too can go up sometimes. So you always need to check. And then, of course, they have what we call dilutional hyponatremia. When you check, they do a BE and creatinine and it comes, you realize the sodium level is low, and it's because they are retaining excess fluid. So it's sort of diluted the little bit of sodium there, and it's giving you an impression of hyponatremia, but this is actually what we call a dilutional hyponatremia. If you check your serum TSH levels and your TSH levels are actually reduced below the normal range, then it tells you that, okay, your pituitary gland is not making enough TSH. And so clearly it's actually not stimulating the thyroid gland to make T3, T4. And so the problem is coming from the pituitary. So this becomes a secondary hypothyroidism. But if you check and your T3, T4 levels are reduced, but your TSH levels are high, then it tells you that this is a primary hypothyroidism, because one, T3, T4 levels are reduced and the pituitary is forcing it to make more T3 and T4 because it's reduced. So it tells you that the pituitary is actually working because TSH level is high, but the thyroid gland is not working. Because even though the TSH level is high, ideally then T4, T3 should also be high, but it's actually low. So this would be what's a primary hypothyroidism. Okay. Are we okay, please?
Yeah, Doc.
Yes, please.
Yeah, with the clinical signs with the woman, the client feeling, can it be likened to Rigor? And if you should check the temperature, would the temperature be low as well, or just like it too? No, with the complaint low is what we liken to.
Okay. Okay, so yes, so because of that cold intolerance, sometimes when you check the temperature, it's not a classic feature that when you check the temperature, you realize that the temperature is low. Sometimes you realize that the temperature is a little bit low, but it's not like a classic thing that will go with it. Sometimes they might even have the normal body temperature, but it will tell you they are feeling cold. Did you get it?
Yes, sir.
And it's not like a classic thing like they'll be shaking and all that, but then in severe form, which we'll be looking at in a bit, they would have something like that where they are shaking seriously. Okay.
Okay, thank you.
Okay. Just a minute, please. So in terms of the investigations, this is what we do, as I said. So you try and go through. In a very severe form, so per the question, the last question that was I was asked, in this form, the temperature is actually low. Temperature can go below 34. We say the patient becomes hypothermic. So in that severe form, that is when we tend to see the temperature drop very low. But not every patient coming to you with a reduced level of thyroid hormone, or every patient who you say has hypothyroid would have hypothermia. No, you tend to have hypothermia in the severest form of hypothyroidism. And this is called mixed edema coma. Okay, so in mixed edema coma, the hypothyroidism is that severe. The patient will come to you with an altered mental state. There'll be hypothermia. Everything will be slow. Breathing will be slow. Pulse will be slow, as you can see. So there's hypothermia, hypoventilation, bradycardia, hypoglycemia, and hyponatremia. And this may lead to coma. Okay, so this is what we call mixed edema coma. Okay, and usually once it happens like this, we know that the main issue is that the patient doesn't have thyroid hormones. So we need to replace the thyroid hormones. Okay, so most of the time we'll give IV because it's an emergency. If we are managing on an outpatient basis where it's not an emergency, you put your patient on oral levothyroxine. But in this case, we are going to give IV T3. T3 is the most active form. Usually T4 has to be converted to C3 for it to be able to work. But we don't have time to waste in an emergency setting, so we'll give straight away IV T3. Okay, we are giving about 2.5 to 5 microgram every 8 hours. We're giving your patient oxygen. We need to warm your patient and get a good temperature. And then we also give them hydrocortisone, 100 milligrams 8 hours. And then we also give them glucose infusion as well. Okay, so and this is the clinical presentation that you get. Okay, so once the patient is out of that phase, or once you make a diagnosis of the patient who is hypothyroid at the OPD, you've done all your investigations, you need to put your patient on thyroid hormone. So we usually give them levothyroxine, 100 micrograms daily, and we put them on that. And then you just have to monitor your thyroid function test regularly until you are getting a good level. As you can see, you can increase your dose or you can decrease your dose and then maintain to about 100 to 150 micrograms a day. Okay. So basically that is hypothyroidism for you. One, just know that hypothyroidism means that you have diminished amount of thyroid hormones, T3, T4, that's one. Two, know that it can be primary or it can be secondary. Three, know the clinical features, and usually it's basically due to slowness of your metabolism. And then four, know that you can have an emergency condition called mixed edema coma, where everything becomes extensively or very, very serious. Everything just goes down slowly. Okay, and five, know that your main management is to try and replace the thyroid hormone levels whilst you also investigate the cause of the hypothyroidism. If the hypothyroidism is due to probably some tumor sitting in the pituitary area, which is pressing on the cells responsible for producing TSH, means that your management has to be directed to that secondary hypothyroidism. You need to go and remove the tumor. Okay, once you remove the tumor, you might not even need to put the patient on levothyroxine. Once you remove the tumor, the cells making the TSH will start functioning normally, and then it would make the thyroid hormones better. Okay. Otherwise, you need to manage and then give your replacement hormone therapy. So clearly, hyperthyroidism, straightforward, is going to be the opposite of what we've talked about to hypothyroidism. As you can see, in this case, you have excess thyroid hormones. Okay, you have excess thyroid hormones in this case, and one, it can be primary, as I said, or it can be secondary. Primary means that the thyroid hormone, the thyroid gland has gone haywire and it's making excess thyroid hormones. Secondary here means that the problem is above the thyroid hormones. There's excess stimulation from the pituitary, which is making the body, basically you are making more TSH, and this TSH is stimulating the thyroid gland, and then you are making excess thyroid hormones, okay? And that means that you have a secondary hyperthyroidism, okay? So in severe cases, or sometimes the increased hormonal level will lead to what we call thyrotoxicosis, okay? So not every patient who has hyperthyroidism will have thyrotoxicosis, no, okay, you get it? So that's the difference. But a patient who has thyrotoxicosis has hyperthyroidism. So thyrotoxicosis is a hypermetabolic condition, okay, under hyperthyroidism. Okay. So in terms of hyperthyroidism, what causes hyperthyroidism? So you can have, one of the most important causes is what we call a Graves' disease. Okay, it's important because the management is so difficult, and it can happen to, I mean, young people as well. I currently have this young patient I saw. It brought to the OPD about 3 years ago when I was in private practice. The presenting complaint was that, one, she sweats, she sweats too much. She's always sweating. And two, she's always angry, like she's always upset. The slightest thing gets her upset. That was the presenting complaint. So if you are sitting in the OPD and you get this complaint, you feel like, this is a very bizarre complaint. I mean, sweating too much and always getting angry, you are bringing this to me. Go and see the clinical psychologist. But no, that is how the patient presented. And through history taking and examination, the mother attested to the fact that, oh, well, the eyes are even getting big now. They are bulging out. Now she eats a lot. She's always hungry and she's losing weight. And clearly that made the whole scenario, perfect. This is hyperthyroidism. It made the diagnosis relatively easier. Okay, so you always have to take a good history. So this patient actually has a Graves' disease now. I referred her to the endocrinologist at Kolebu after starting her on some anti-thyroid medication. She's doing well, but now the problem is that she has to be on it for a very long time because it's an autoimmune condition. You have to live with it. You see, that's the sad aspect. So a Graves' disease is an autoimmune condition. And basically, you have what we call the thyroid stimulating hormone receptor antibody. This is IgG. Okay, so this TSHR antibody, what it does is that it goes and it binds to TSH receptors, okay? And when it goes to bind to TSH receptors, it sort of that we don't have enough T3 or T4, so make more T3 antibody or autoantibody goes to bind to this TSH receptors and it causes it to make more T3 and T4 basically. Okay, that's Graves' disease. And then there's also what we call toxic multinodular goiter. So you see people who have goiter and their goiter is not due to iodine deficiency. All of a sudden the thyroid glands start getting bigger and then it starts making a lot of thyroid hormones. Okay, sometimes you can have a very tiny nodule which is making excess hormones. Okay, and then of course you can have a viral inflammation of the thyroid gland. Sometimes when you introduce radiation to the thyroid gland, you basically open the thyroid gland up and then you release the thyroid hormones into the bloodstream. Then I've already talked about amiodarone. Once you take amiodarone, it can actually destroy the thyroid gland, and in the initial phase, it causes release of excess thyroid hormones in the bloodstream. Of course, people can also get pregnant, and because of the human chorionic gonadotropin hormone, it causes you to make excess thyroid hormones. Okay. The clinical features will be opposite to that of the hypothyroidism. In this case, there will be weight loss, there will be increased appetite, the patients will have tremors, there'll be heat intolerance, patients will be very irritable, heart rates will always be high, patients will be having palpitations, and patients will have constipation. They will also have goiter, okay, as we've seen, especially in Graves' disease, they tend to have goiter. They have eye complications, so the eye pops out, what we call proptosis or exophthalmos. Then they are always looking at you when they look at you, it's like they are staring at you, but it's because the eyeball is just out, okay? And then they have a lid lag. The eyelid is always lagging behind because the eye is popping out. Then they have what we call ophthalmoplegia because the muscles moving the eye basically become infiltrated and it becomes paralyzed. Then they can also develop what we call a Graves' dermopathy. So in front of their shin, you realize it looks a little bit puffy. Then they have what we call a thyroid acropathy, where their hands would also swell. Basically, in this goiter, eye complaints, Graves' dermopathy, thyroid acropathy is common in Graves' disease, and it's because of infiltration of some, should I say, a sugary substance or a glycosaminoglycan, so it sort of infiltrates the body tissue and then it becomes puffy. You will see pictures shortly. Then they can have amenorrhea or oligomenorrhea. They can have loss of libido. So this is a picture of the proptosis. You can see how the eye is staring at you. This is a thyroid acropathy where the hands are basically swollen. And then you can see this is the pretidial myxedema we talked about, where their shin becomes infiltrated and it looks puffy as well. Investigations, we need to check the serum TSH. Usually when the T4 and T3 levels go up in a primary hyperthyroidism, it would exert a negative feedback on this, as you can see. And once it exerts the negative feedback, it causes it to become suppressed. So you have a patient who has very high T4, T3 levels, but reduced TSH levels, as you can see, okay? And then you also can check your anti-thyroid peroxidase antibody. And then this is a TSHR antibody we talked about in the Graves' disease. You can test for all. You can introduce radioisotope into the patient and then you scan. Once you introduce a radioisotope into the patient's blood, it will collect more in the thyroid area. It tells you that the thyroid is overproducing something. So you scan and then it tells you, okay, you actually have a hyperthyroidism on your hands. So in managing, we give medications that affect various pathways of the thyroid hormone production. Okay, so we can give carbimazole, and then we can also give what we call propyltyrosol. Okay, and basically they act to inhibit production of T3 and T4, as you can see. Okay, so the dosing is there. You give and you always titrate until you get the actual dose that's the patient need, and that will bring the level of the hormones down nicely. So as you give, you keep doing a thyroid function test to ensure that the hormone levels are reduced. Okay. So in terms of management, as I said, you have pharmacological management or medical management, and that's where your thyroid hormones come in. Of course, you can see the side effects that it comes with, so you should know. Then there's also the role of giving beta blockers because of the increased pulse we talked about. So the beta blockers will help to regulate the pulse and whatnot. And then there's also a role for radioactive iodine therapy where you introduce radiation. You introduce the thyroid gland through radiation, and this radiation destroys the thyroid gland. And so once it destroys it, the thyroid gland is unable to make thyroid hormones. And once you do this, it means you've rendered the patient hypothyroid. So then you need to put your patient on daily hormone replacement. Okay, otherwise now your patient is going to suffer from hypothyroidism after you move from hyperthyroidism. And also you can do surgery for the patient by going to remove a goiter that is making excess hormone, so a thyroid that is making excess hormone. You go and you remove it, and once you remove it, you need to put your patient on hormone replacement, which is levothyroxine. Okay. So this is also the emergency medicine aspect, that in severe cases, just like the way in severe cases of hypothyroidism, you can have what we call myxedema coma. In severe cases of hyperthyroidism, you can have what we call a thyroid storm, and everything goes way above level, way overboard. Okay, so there's tachycardia, which is so high, BPs would go up, patient is in respiratory distress, patient can go into coma and everything. And this can either be induced by probably an infection, or the patient is going for surgery, or patient is having an anesthesia. There are a lot of things. If you have a DKA, all of this can cause a hyperthyroid patient to go into an overdrive, and you are going to have excess hormones being produced, and this can actually kill the patient. Okay, so once you make a diagnosis of a thyroid storm, you have to manage in an ICU setting. You basically need to support your patient. You're giving oxygen, you're giving IV fluids, and then you are controlling the increased body temperature. Then you control the pulse by giving your propranolol, as you can see. And because the patient sometimes the coma unable to swallow, so you have to pass an NG tube and give your propranolol. Okay, and then you have to give your carbimazole or your propylthiouracil just to regulate the increased hormone levels. Here to IV hydrocortisone is very essential. You give it to the patient, and then what it does is that it prevents conversion of T4 to T3. And we are saying that T3 is the active form. So we don't want you to make more T3. So we give you IV hydrocortisone, and then it prevents the conversion of T4 to T3. And then you just have to manage the underlying illness. So it looks a lot, but it's quite straightforward. During our emergency medicine sessions we'll be having in about a week or two time, we'll touch on this thyroid storm and myxedema coma briefly. I mean, in 30 minutes, we'll touch on it again, but it's part of your slides, so you should just go through. I think time is fast spent. I'll take your questions, and then we can close for today and meet tomorrow.
Sir.
Yes, please.
Please, is there a big deal of you taking iodidated salt for hypothyroidism?
No, it's not. It depends on the cause of the hypothyroidism. If the cause of the hypothyroidism is iodine deficiency, why not? You need to take the iodidated salt, because that is what will solve your issue.
Okay, sir.
Yeah.
Hello, sir.
Yes,
hello.
Hi.
Please, the surgery, the thyroid gland.
Yeah.
A man complained his thyroid gland is removed and he speaks like a lady. The voice, whenever he speaks, is like he speaks like the voice changed, and he's on a drug, daily drug for life. So I don't know how come.
Okay, so so one, the daily drug he is on for life is the levothyroxine. As I said, if you remove the thyroid gland, you need to replace the thyroid hormones. You understand? So because if you remove the thyroid gland, they are trying to replace the thyroid hormones, and that is why he is on levothyroxine. The reason why the voice is like that is before you do a surgery, I didn't show you the nerves, but there are nerves also moving around the blood vessels. And there's a nerve called the recurrent laryngeal nerve, okay, which is very essential. It helps our vocal cord and you're able to talk and all that. Before you do any surgery, you have to do a laryngoscopy and check if what we call the recurrent laryngeal nerve is there and is working fine. Because if you do your surgery, one of the risk factors which Dr. Nutako will teach you when you do a thyroidectomy is that you can end up cutting the recurrent laryngeal nerve. And once you cut it, then it means you are going to worry the patient's voice, and the patient's voice will change after the surgery. So that is probably what happened to the person. It's because of a complication of the surgery, damage to the recurrent laryngeal nerve. Okay.
Okay.
Okay, so I think we can end here. Tomorrow we'll do rheumatology. We'll do SLE and rheumatoid arthritis. It's also straightforward. I'll try to simplify the slides. And then hopefully tomorrow after the lecture, I'll give you topics on infectious disease, which you'll be presenting to me next week, Sunday. So you prepare for that. So have a good night and we'll meet again tomorrow, God willing. Okay.
Okay, good night. Night.
Okay.
Bye.
Okay, good night, sir. Hello, sir.
Yes, please, Thomas.
The presentation, are they going to be the midterm?
Yes. Just like what I did for your senior colleagues, that would be it would form 30% of your marks because everybody has to do well. Okay.
Okay. Sir.
So divide yourselves into your class is quite large. So you divide yourself into 6 groups. Okay. And then, so you can start a division now, and then I'll give you 6 topics that you'll be presenting on.
That's the regular.
No, so you can, I don't know how you go about it, but you can do it as a class. It can be a mixture. I prefer to be a mixture of regular and weekends in one group. So you form 6 groups, and then I'll give you topics tomorrow, 6 topics tomorrow, and you start preparing on it as a group. I'll give you more details on that tomorrow.
Sir, Doc, the mixture will be a problem.
The mixture will be a problem.
You have to find a way to make it work. I prefer that. I want.
To be honest.
Yes, but you should one important way of learning is what we call team-based learning. You should be able to learn and practice as a team. So this one is non-negotiable.
Thanks for that, Doc.
So find a way to make it work. We'll get more details. I won't be the one regretting. If I'm regretting, it means your marks. It means it will affect your marks. I won't be the one regretting at all. All right, okay.
Good night, eh? Bye-bye.
Yeah, enjoy your evening. All right, okay.
Thanks,
right.
Doc. Thanks, Doc. Thanks very much, Doc.
Okay. All right, okay. Bye.
Okay, bye.
Bye.
Good night.
Good night.